Dear committee, let me introduce the second candidate from the Department of Prosthodontics. So, János König was born in Békés Csaba and graduated summa cum laude as a Doctor of Dental Medicine from Semmelweis University in 2016. He became a certified specialist in conservative dentistry and prosthodontics in 2019 and completed a second specialization in prosthodontics in 2022. Since 2016, he has been working at the Department of Prosthodontics. He is actively involved in both undergraduate and postgraduate education. He teaches prosthodontics in Hungarian, English, and German, and contributes to the digital dental design program through multi-semester courses. Since 2020, he has also been teaching in a postgraduate program, and since 2024, he has been mentoring resident doctors in prosthodontics. He is a member of the Maxillofacial Rehabilitation Working Group and the founder of the Complete Denture Prosthetics Working Group, which was awarded a faculty research grant in 2024. He also played a key role in establishing the department's digital laboratory. His overarching goal is to improve patients' specific outcomes in the rehabilitation of completely dentaless patients, maxillectomized patients, and individuals with facial defects.
Thank you very much, Professor Herman. So now I'm asking for the candidate, János König, to present his thesis in the limited time, please.
Dear committee, during my PhD journey, my mission was, or my vision is, that I have to establish or start to establish the base for an evidence-based maxillofacial prosthetics. And to establish this, we have to first establish a proper scientific output for our working group. And my specific goals were, the first one is about optical scanning in facial prosthetics and the comparative analysis of hemimaxillectomized patients. Well, the first topic revolves around the individuals with facial deficits, because more than 650,000 people are developing head and neck cancers every year globally, and a fraction of them would result in a defect on their faces that is irreparable surgically, and the only solution is the prosthetic treatment. But since it is inaccessible for many, we need something to advance the allocational problems and the accessibility problems for this slice of patients. And due to a trickle-down effect, one might say that digital face scanning would be the proper solution to this, because digitizing some otherwise conventionally working workflow would eventually, in the long term, in the long run, make the costs and the accessibility lower. I mean, the cost lower and therefore the accessibility higher. So we are in a need to have a reliable alternative, and this might be the way. Our aim was to compare the trueness of different surface scanning technologies, because what we see, if the model, the facial model that the prosthetic will eventually be fabricated on is inaccurate, then gap formation can occur between the skin and the silicone body of the prosthesis. And well, the threshold for this gap that one might see or not see is controversial still. I have 3 different sources claiming 3 different thresholds for the same gap size, so it's still not a established threshold. So our clinical question was that how did these 3D imaging technologies perform on different parts of the human face, and therefore we've compared interlandmark distances that were measured on the face and on the virtual models after scanning and digitization. And comparing these two values would result in a mean difference or a difference that would be counted as the deviation from the true values. And the null hypothesis was that there will be no difference between scanning technologies and nor facial regions. We've conducted a systematic search in 5 databases in 2021. And our strategy for the data synthesis was that if an interlandmark distance is present in 3 different articles, then we've conducted a mean difference meta-analysis. If the interlandmark distances in different regions are not the same, then we group them up into a pool, and then we conducted a standardized mean difference analysis, but this comes a little bit later. The results were that let's just show the measurements from the nasal region. For example, the distance between the 2 alare points. One might see that the pooled effect size is much more narrower, so the 95% confidence interval is narrower than the individual articles' effect size, the confidence intervals. That would mean that the imprecision that are present in the individual articles are, by the law of large numbers, are the imprecision is lost when we pool the articles together. And we see the same phenomenon in the other interlandmark distances, in the other nasal measurements and in the peri-orbital measurements, and also the perioral measurements, that the diamond at the end of the forest plot or the bottom of the forest plot is much more narrower than the individual articles. Now, as for the second part of approaching the same problem from a different direction, was that I've categorized each interlandmark distances into, I assigned them into a region and assigned to them a certain direction. So will this interlandmark distance characterize the face in the vertical or in a left to right axis, and so on and so on. And then, since, for example, these interlandmark distances, the nasion subnasale, nasion pronasale, and the gnathon subnasale, or the glabella subnasale, is characterizing the length of the nose, but since they are measured in between the different points, they are incomparable to each other, because the magnitude is, of course, different. But transforming the face linearly by conducting a standardized mean difference analysis will make them comparable. But instead of showing you the individual forest plots, I made a table that would summarize the findings in the oral labial region along the Y, along the X, and along the Z axis, the nasal region, and the periorbital region. A green color code is showing you a slight magnification that our measurements are above 0, and different shades of reds are showing slight shrinkage. And even with this very inclusive methodology, the auricular region, the data for the auricular region was insufficient. We've also collected the common issues that were mentioned by the authors regarding what were the difficulties during the scanning procedures, and the most common ones were landmark identification, because that's just a problem for the measurements itself. But the one that we are interested in is the hairline intrusion, blinking, and other motion artifacts that were causing troubles with the mesh production. The risk of bias assessment showed an overall low risk of bias. It was measured with a custom tailored Quados 2 tool, and the grade assessment showed a moderate certainty about our findings. So that would mean that our future research could, but not not probably, but could influence, could alter these findings. So our conclusion is that the dimensions of our scan models are not significantly different compared to the true values that was measured on the face, and the accuracy, unfortunately, is still not in the acceptable range in every region, and the clinical usability differs substantially based on the technology. So, as a summary, we can say that scanning could be or should be preferable over traditional impressions due to the lack of skills. One might say that the learning curve of scanner usage is much more not that steep as for the traditional facial moulage impressions, but of course we need further studies to explore this kind of questions. The second project is about hemimaxillectomy patient, because after a hemimaxillectomy that would result in a defect like this on the picture, one might face two different directions. Either one might reconstruct this defect surgically or prosthetically, but the choice, unfortunately, is based on the operator's own personal decision and not like guided by evidence-based guidelines. So our aim was to compare the therapeutic effect of these two main solutions. Of course, there's some granularity in this question, so not every hemimaxillectomy defect is the same, and not every patient can easily be put into the same bin. But our question was that whether they have any kind of differences in the quality of life scores in different domains, masticatory indices, speech intelligibility, and also nasal length. And the second question is that how do, and if the basic characteristics of patient can have any influence on the outcome that could be discovered in a meta-regression. A systematic search was done in 4 databases, and what we found is that in the columns you see the most commonly mentioned or employed or deployed questionnaires or quality of life assessment tools, and the rows are showing the individual domains that these tools are assessing. And since there's a wide variety of different tools in this pooled article, we've decided on to do a meta-analysis on the results with the University of Washington Quality of Life tool and the shared domains between the University of Washington and the EURTC questionnaire. So therefore, let me show you the University of Washington Quality of Life questionnaires. In every domain, there's a very slight tendency that favors surgery, but unfortunately the 95% confidence intervals are way too wide to conclude or draw any firm conclusions, with one exception, which is the activity domain, which has a really small score change that was actually mathematically significant, but a score change of 2 in a scale of 1 to 100 is not clinically relevant at all. Some say that with this, of course, it differs from tool to tool, that a score difference of 20 to 30 would have any kind of clinical relevance. The subjective measurements, such as the shared domains of different quality of life measurements tool, show the same tendency that actually the point estimate is that show that the results favor surgery, but of course statistically there's no significant difference between these two rehabilitation method group. And the objective measures that were the nasal length, the masticatory performance, and the speech intelligibility show the same general phenomenon. And the masticatory performance in this study was compared with a standardized mean difference, because the 3 articles included used 3 different methods to assess the mixing ability or the masticatory ability of a patient. Now the thing is that usually that was mentioned in 3 articles at least, that some baseline differences could set the obturator group back. For example, the follow-up measurement was sooner in the obturator group in the Al-Adashi et al. Article. It was the only randomized controlled trial in our meta-analysis. And they compared apples to oranges, so a definitive surgical solution is compared to a surgical obturator, which is a temporary solution, prosthetic-wise. So given this very huge difference, one might say that the conclusion that can be drawn from these results are quite weak. Unfortunately, given the heterogeneity of the included articles, these questions regarding the influence of basic characteristics could not be answered because the method regression was not feasible, because we should have had 10 reports at least that share the same outcomes. The risk of bias tool, the risk of bias assessment showed that there are many biases that is abundant in the included articles, with one exception, again, the sole randomized control trial. The certainty assessments shows that the subjective evaluations have a low certainty that would easily be changed with new results, and the objective evaluations can be treated as moderate evidence. Our conclusion is that the data available currently is not suitable enough not suitable for drawing any firm conclusions. Therefore, one might say that proper trials with proper scientific methodologies should be designed, and then patient registries should be started for these patients group to draw a firm conclusion here. Well, during my PhD, during my last 4 years, these projects sparked some new ideas regarding new studies. For example, the first one sparked the drive to determine the different printing attributes to allow us to fabricate 3D printed casts and 3D printed copies of pressing tools for silicone epistheses. The PREDICT study is what resembles this second meta-analysis, which aims to find different anatomical factors that could influence the prognosis of complete dentures in edentulous patients. And given that during these 4 years, I find myself absolutely influenced by data and numbers, I even enrolled into a data scientist online course and plan to enroll into the applied biostatistician MSc program in September or maybe next year. But most importantly, hands down, my biggest achievement from last year is my son. Not to downplay the Center of Translational Medicine, but I guess it is the most important one. Thank you for your kind attention with a quote, with an African proverb that until the lion learns how to ride, every story will glorify the hunter. Thank you.
Thank you very much for this very interesting and complex presentation. Now I will proceed to the questions. First, the opponents.
Okay. Thank you very much for the presentation. So I have, you did 2 excellent systematic review and meta-analysis, and systematic reviews has several purposes. And one of the purposes of systematic review is to define direction for future research. And what would be the most priority for future research for these two meta-analyses that you presented?
The first one, I guess, is to, well, the results of this first meta-analysis shows me or suggests me that the scanning is should be not an issue. But after the scanned model is on my computer, then what happens next? So I've tried multiple times with different workflows to fabricate a facial prosthetic appliance for a patient that was previously scanned. And since there's no current way, I mean, no actual way to 3D print or like directly manufacture a silicone prosthesis currently without any pressing tool or any further working steps. So then I guess the main, the most important direction of the research is to we have to have a solution to directly print silicone materials that is absolutely, let's say that it's the coloration is either intrinsically solved or it has the further possibility to extrinsically color to match the patient's color. Thank you.
Okay, thank you for your nice presentations. First of all, I have to hand over my gratefulness because you are dealing with very important part of the prosthodontics. I have two small questions. You know, I know that your research work didn't aim the type of the scanners, how influence maybe your final results, but maybe the spatial resolution in case of this, because you're mentioning that maybe respectively the anatomical sites, you have to determine which is favorable, which is unfavorable. For the future, the spatial resolution, how influence this work? Because you know in the normal scanners, always you have to set which type of scanning would you like to select. For example, in case of the prepared teeth, clinical abutment or any other else, it has a more or less impact on the outcomes in terms of the accuracy. And the other question is that maybe the inaccuracy, you are mentioning that sometimes the inaccuracy, which can be 0.3 millimeters, you can compensate this inaccuracy with acrylic adhesives or maybe vessel lines. Could you determine for myself or the audience that what is the range of that can be compensated with these techniques? Sorry for these two long questions.
Thank you for the questions. For the first one, we did indeed do a subgroup analysis on different technologies available, and unfortunately, they are not designed to accommodate for this very special purpose. They are designed to reverse engineer a piece into different parts, so they are coming from the industrial direction. So they currently don't have the possibility to, change the attributes of a scanning, the capture to a certain region, just like with the intraoral scanners for abutments and for the whole jaw and so on and so on. So, but what we've seen, and unfortunately this idea was only occurred to me this year, like 3 years after the publication, that we should have compared the actual, the specifications of different products by the resolution, the field of view, and so on, but of course I was a bit late with that. And for the second question, this statement, this claim originates from a British facial prosthetist, and he also added the for the requirements that these small inaccuracies can be masked or vanished with applying a little bit of adhesive only on the circumference of a facial prosthesis, but only if the edges are made out of a much more softer material. So a hardness is much more lower than the other parts of the facial prosthesis. But this also means that now the softer edges are more prone to damage. So I guess it's not about the real accuracy, but also the lifetime of the prosthesis too. Because if the edges are roughened up or discolored, then the gap formation is like secondary or even tertiary compared to the color difference.
Thank you. So I will now continue with the gap, because that you mentioned in the beginning for your first study. I was just wondering, when reading that, you said the gap is important for aesthetics, but definitely also for friction and infection. But how much of this research which you included or found actually considered the gap as a kind of outcome factor? The gap or the edges, and because that's indeed the part where even the printing it needs to be thinner and thinner and thinner, and not every material can do that. But
Yeah.
So please comment on that.
Unfortunately, there's absolutely no literature currently about the different workflows compared to each other in the field of facial prosthetics. Only one systematic review was written that compared the different outcomes only. So this is like a million different islands across the globe. So there is absolutely no information regarding that. I have no information regarding that. If there's any study that would use this gap formation as an outcome.
Okay. And during your systematic review work, did you also collaborate or talk to anaplastologists who, you mentioned them obviously, but did you visit some lab or these kind of things? Can you comment on that?
Yeah, unfortunately in Hungary, I only know one person that is actively and professionally creates facial prostheses. And she said, cutting every kind of further discussions, that the edges of the future prosthesis should be engraved on the model. So it doesn't have to be on point precise, just like a finishing line on a prepared abutment, because the compressibility of the skin can be tamed to our advantage.
Yeah, and the weather conditions and things like that. Mm-hmm. Okay, I have more, but
okay. So, thank you. It was a very nice presentation. What would you say that contributes the most to the error in producing dentofacial prosthesis? Is it the shrinkage of the impression material or the plaster? Is it the elastic deformation of soft tissues? Or is it the imprecision or the accuracy of the scans?
Because of the weight and the elastic deformation upon withdrawal of the impression material, and also the skin compressibility, these are much more, so these are adding up to a magnitude higher level than the imprecision that we saw in the case of scanning technologies. So I guess even with this very strict threshold of 0.3 millimeters, these are much better than any kind of plaster or any kind of alginate that could be applied to a patient's face. Not to mention the withdrawal. So if there's any kind of undercut that needs to be blocked out, or if you forget to block it out, then during the withdrawal, this excessive force can then irreversibly alter the dimensions of the impression itself.
Okay. And what would you say, is there a clinically relevant difference in accuracy or precision in difficult to capture and easy to capture regions?
So is there a different threshold to them?
Yeah.
Yeah, it needs to be, I mean, further, it needs some further research.
Is it clinically relevant? That's the question.
Well, in an auricular region, I guess, the target specification should be much more stricter than, for example, in a wider region such as the buccal region or so. Not to mention the motility of the surrounding tissue. So, for example, a really small amount of people can move their ears, but most of us can move our jaws. So therefore, this area of this skin area will have a higher range of motion or a bigger range of motion. So therefore, yes, I guess in certain regions, my hands down my favorite is the auricular, because that is much. So that is really difficult to capture because of the strange anatomy, and therefore, given that this difficult anatomy could result in a even less accurate scan, but even though in this region we might need an even stricter threshold.
So there are areas where it is more important because of the aesthetics and less important. It's
Yes.
not related to easy to get.
Yeah, yes.
Okay, thanks.
Okay. At one moment, because now I have to invent a question, but at one moment you said that the surgical procedure, which he's going to comment on probably, the surgical procedure is still favored, but like, of course, for some areas, surgery as such is not sufficient. Can you further comment on that?
Usually there's a general rule of thumb in the literature that is not supported by any evidence, is that if one might have a big defect, then surgery is the way. Then prosthetic appliance is the way, because surgery is now considered, surgery will consider it an unrepairable defect. And for smaller defects, one might say that it's easier to close with a flap these kind of areas. But my personal experience is quite the opposite. So with the advancements with free flap surgeries from fibulas and the iliac crest, more and more patients are coming with a big defect that was already repaired surgically. Maybe not completely, but now the defect, now the communication, the oral nasal communication is then solved, so then closed. But unfortunately, from the prosthetic point of view, if this defect is lined, or this transplant is lined with skin, and the patient does not have any teeth or any bone to receive implants, then the prosthetic appliance that is skin-borne will have a really poor prognosis, unfortunately. So one might say that the defect is now surgically repaired, but the dentition is then, the prosthetist will face an even bigger difficulty.
In fact, half of answer it's already made, but you prefer to make surgery reconstruction. In my opinion, what is important, as you already talked to us, it's the presence of the teeth into the mouth. So what kind of reconstruction do you prefer? Bone reconstruction or only with soft tissue?
I mean, it heavily depends on the situation, unfortunately. So these patients are, even though if the diameter of the defect would be the same in two patients. The other characteristics, such as the remaining dentition, whether he or she received radiotherapy, whether the defect is skin-lined or not, is accumulating into a final decision for the final treatment or final rehabilitation. And this is what I find painful, because there's no structured guideline for all of us in this country that we can follow for each and every case.
And if we talk about epistasis, when you scan the defect, do you think also to a system of anchorage for prosthesis?
Yeah, that would be even better to align the facial scans with CT scans that we can use for even implant placement. And as a guide, we can design even a guide to implant placement, but currently I guess this is science fiction. In my opinion, to get a facial prosthesis driven implant retained prosthetic appliance.
It can be something relatively easy. For example, you have implants with magnetic abutment. Price, it's quite normal for an implant. So to put an implant to put an implant and magnet in both sides of it's not very complicated.
But unfortunately, in some occasions that the implant itself and the abutment and the space needed for this whole structure is right in the way of, for example, the eyeball. So I have had multiple occasions where this was the issue, that the positioning of the, let's say this is an orbital case, the positioning of the eyeball was completely a disaster because of the surrounding implants that were placed not guided.
When you make the scan, it is quite obvious that for hard tissue it's not a problem. I think also in terms of accuracy. Do you have a preferred position to have all the impression in the same fashion with, I don't know, a patient need to take the maxillary bone in the same position with mouth opening? Do you have a special position of the maxillary bone when you make the scan to have the same accuracy of the scan?
So can you rephrase your question?
I think when you have close strength the mouth, you have a position of the soft tissue. When you open the mouth, will be a different position. Do you have a standard position of the maxillary bone when you make the scan for prosthesis, at least for the mid-face defect?
Well, usually it's placed in the alveolar bone from the other way around. So it's not from the oral cavity, but from the nasal cavity. As far as as far as the cases I met, any kind of other, for example, in a mid-facial defect, any kind of other bone in the area, I guess it's not thick enough to receive an implant. So, for example, the os nasale or the orbital bone, and so on.
I refer that the position of the soft tissue here will be different. So when the patient will move the mandible, it's in fact a matter of a gap between the prosthesis and the face.
Yeah, therefore we can engrave it into the, these edges can be a little bit deepened into the skin. Of course, that would be a nice thing to have that we can multiple scans to accommodate this range of motion, but currently this is much more static than that.
So, First of all, it was a great presentation and a very interesting subject. But regarding your first project, I was wondering that since different ethnicity of population might have some different interlandmark distances or skin tone or soft tissue, I was wondering if that it might cause some accuracy differences while scanning. I was wondering, how did you assess that in your population, or did you come across some articles that the difference was negligible?
Good question, thanks. Well, the standard deviation of the individual articles already shows they are wide because of the individuals have different sized faces or heads. But regarding so it was not. Our calculation was not standardized to that because we couldn't do that in a secondary way. And for the skin color, it's an interesting take on the optical scanning, whether the color of the skin or color of the target could influence the accuracy or not. This was not accounted for.
And do you think it might need some further research in the future?
I guess only with people with different configuration facial deficits.
Thank you. Thank you for your answer.
So in your first figures, I realized that you have articles, the Jodah, or I don't know what was the name, you have duplicates. That was some dependency issues about it?
No, they employed different techniques, different scanning technologies. No. They used three groups of patients compared to a reference. So this is there were different age groups of children in that article, and therefore they are not summed up, but taken into different rows.
There was different populations. Thank you. And another question that you used several times, the SMD, and that studies sometimes with small number. And in that case, it's important that what kind of SMDs are using. So the HSG or the Cohen, or whether you know that it was, or it was hidden by the statistician what was used.
So, for example, this one, these were Cohen's D, but in the end, this 0.15 is 0.01 is a dimensionless number, so it's not like millimeters at this point, because it's already divided with the pooled standard deviation. So this doesn't mean that the difference is in a 10 micron level, but just like not a ratio, but like it just only shows you the direction, whether if it's magnitude, whether if it's magnification or shrinkage.
Yes, the question is regarding to how they calculated the SMD for the individual studies. Because if you are using the Cohen D or the HSG, that confidence interval could be in small studies very, very different. And the analysis could be very different based on that.
I mean, it was calculated by, every mean difference. I mean, the pooled mean difference was divided by the pooled standard deviation. Which one is the Cohen's D?
Yes, the confidence interval, it's totally different for them. That's not okay. Doesn't matter. Thank you.
Thank you very much. So, any further questions? If not, thank you very much for the candidate for the presentation and answers. Congratulate for the candidate. The points are 23 of 25, so it's 4.6 the average. That means the qualification of the degree is summa cum laude. Congratulations.